As you mentioned, I'm an assistant professor here at Indiana University in the Division of GI and Hepatology. My clinical practice is in both end-stage liver disease and transplant. My clinical research is focused on really predictors of healthcare utilization and more recently in how patient-reported outcomes can impact our clinical care. So I'm excited to talk to you about this topic. Oops, hopefully. Okay, so I have no financial disclosures related to what I'll be presenting today. And I'd like to start really with why this has become a research interest of mine, and it really comes from the clinical care that we provide. As I finished my training and really decided that research would be a part of my career, I was urged by some of the implementation care scientists who I was training under to observe the clinical care that we provide and try to find gaps in our care. And as I deeply observed, there were many stories like the one I'm about to share with you that motivated the work that I am pursuing. So Mr. A is a patient of mine who is actually a nurse, and he presented with a variceal bleed. And this was his first sort of run-in with cirrhosis. He was diagnosed during this hospital admission. He also developed hepatic encephalopathy during this time. So through all of the great medical care we're able to provide, from endoscopy to beta blockers to medications for hepatic encephalopathy, management of his malnutrition through tube feeds, et cetera, we are able to get him out of the hospital and stay alive despite the severity of his liver disease. I was able to see him 2 weeks later. He was starting to do a little bit better. However, his encephalopathy was still quite significant, and I had to ask him to stop working and driving. But I was confident that the lactulose and rifaximin that I had started would make him better. So I discharged him from that clinic visit, as I think many of us have seen these patients out of the hospital as we transition them back to their day-to-day life, but had to ask him to stop driving, stop working, et cetera, lots of new medications. As we do routinely, our chronic disease care means episodic care. So I asked him to come back to me in 3 months, at which time he might need repeat endoscopy and repeat assessment. But during that time, those 3 months that elapsed, he was not really in touch with our medical team, short of sending disability paperwork and minimal things like that. So when I saw him again, he had become more malnourished. He was a little disheveled because he had stopped driving. He wasn't really buying healthy groceries. He was not exercising any longer. Because he wasn't working, he was less socially connected. So really, even though I had, what I thought was done a great job of medically managing him, his quality of life, and many of the things that made him feel satisfied with his day-to-day life had declined. And I had missed that opportunity in the 3 months that I had not seen him. So I think that case, as many of us probably can think of cases in our own practice, is really the challenge of outpatient chronic disease management. And we're at the cusp, I believe, of a revolution in how we manage care, what many call healthcare 2.0. So our traditional model is what I just described, right? We see patients with chronic disease. We see them in our own sort of space, or the hospital or the clinic, and then we send them out, we send them back to the community, maybe we refer them to specialists. Really, the model we should be embracing, especially when it comes to chronic diseases that we're going to manage for a long period of time, there should be a more continuous cycle. And digital health applications, as they expand, will really be a key to that. And monitoring what's important to patients, I think, is a key connection between healthcare as we know it now and healthcare the way it should be, which is patient-centered or value-based. There's many terms for this. So what I'd like to do today is talk with you about what are patient-reported outcomes. After some definitions, we'll get into examples of how patient-reported outcomes can actually inform our clinical practice based on trials that have already been done in other disease models. And I hope to use those examples to define some barriers in the use of patient-reported outcomes in our clinical practice. Why aren't we doing it now? Why isn't it part of our care? and then end by linking it to how we can approach it in liver disease, specifically in the area of research. So as you may know, there are many types of outcomes that we follow in any chronic disease or really even acute disease, and patient-reported outcomes are just one of them. So there are also observer-reported outcomes, meaning your nurse or your research technician taking note of a patient's symptom or a complaint. There are also performance-based outcomes such as exercise stress testing, pulmonary function tests would be great examples. There are disease surrogates, for example, MELD score, if I relate it to liver disease. And then there's also survival, which we use very often. And of course, our own reports of how a patient is doing. So really in the world of outcomes, PROs are just one of them. And what is a PRO? So there are some formal definitions for us to review. One is that really outcome data that's directly from patients about their own health and their impacts on from treatments and management within the health system. So really the key here is that it is not interpreted or filtered by anyone else, and it's coming directly from the patient. And as we measure these PROs, we call them patient-reported outcome measurements, or PROMs, which are the surveys or instruments that we use to measure PROs. And I should say, please unmute yourself and ask questions as we go along. I'm happy to stop and answer. So PROs are not a new thing. The terms is new, but we have been talking about what patients value and care about for a long time. You know, Sir William Osler, this is really a meaningful quote to me, so I share it with you, really talked about it's important to know what is the patient who has the disease and not the disease that has afflicted a patient. And I think as we go through medical training, some of that perhaps gets lost because we're so focused on advancing what we know about the disease. Even the World Health Organization has been talking about this for many decades, where health is not defined just by the physical health, but also mental and social well-being in the absence of disease. And as they've evolved in their knowledge of what health should really mean, they focused on how an individual, despite disease, can cope with their environment and realize their aspirations in a safe manner. So in really many definitions of health that are accepted worldwide, it is not just our clinician report or mortality or disease markers, but really what the patients value. In the United States, there's great national interest in patient-reported outcomes. This is an example of the CDC, a project called Healthy People. And as it's evolved over the past 4 to 5 decades, what I'm highlighting here is the incorporation of measuring quality of life, social behaviors, development across life stages within the definition of health by the CDC, and then not just reducing or increasing lifespan or reducing disease burden. And I think the shift comes because of the shift towards more chronic diseases. If we think back to the early 1900s, we were really thinking about acute diseases. And now, even within liver disease, we are faced with chronic disease on a day-to-day basis as compared to decades prior. The US has also engaged in quite a bit of research. So for example, this is a large 10-year project that was funded by the National Institute of Health to develop an infrastructure to measure patient-reported outcomes. This is called PROMIS, which is a patient-reported outcome measurement system. And this project itself has really advanced the field of how PROs should be measured and which PROs we should be measuring. In fact, that has then translated to an entire funding institute called PCORI that started in 2010, which has focused on patient-centered research where often the primary outcomes are PROs. Those are just examples of the United States. But if I go back to sort of the theoretical model, this is not new. Since the early 1980s, researchers have been talking about how patient-reported outcomes can be conceptualized. And I won't take you through this entire conceptual model, but there is a lot of framework in the psychosocial literature about what types of PROs healthcare should be focused on. To sort of make it more simplistic, I share with you these common terms. So for example, talking about symptoms and symptom burden is a patient-reported outcome. Talking about health-related behaviors, such as taking medications, following a particular diet or exercise regimen that we give patients, that is also a type of PRO that can be collected. We all know about health-related quality of life. We also know that patients' functional status, how they report it directly, can be meaningful in addition to how we measure it through, for example, frailty testing. Other PROs that we often collect or are starting to collect even more are health-related social needs. You know, is their built environment set up in a way that achieves health? Are they socially networked so that they have support? In addition, PROs have often been collected by health systems to measure, are we delivering good quality care? Do patients feel safe and heard in the healthcare system? And then we also collect PROs in the world of adherence. Are they engaged and activated to be participants in their disease management? So there are many types of PROs. I showed you some theoretical framework for it. Kind of diving into health-related quality, which I think is often thought of when PROs are mentioned. There are many domains. This is a depiction of many of the domains that can be thought of within health-related quality of life. And if I were to simplify it even more, I would tell you to focus on these three: physical quality of life, mental quality of life, and social quality of life. And these three major domains have guided a lot of the PRO measurement that has happened in clinical. So the question is, as we now understand what is a PRO, how do we use them? How do we use them in clinical care and research and in our day-to-day medical practice? So I'll spend some slides talking about this. There are three domains that I'd like to cover. One is in research, where PROs are often used as primary, secondary endpoints or for monitoring adverse clinical events. PROs are, as I've mentioned, now PROs are used in clinical care, both at the individual level, but also at the system level, whether it's monitoring a health system or the population that a health system is covering. PROs are also used in the, oops, I'm so sorry, in the literature around population health. I've given you some examples of how the US is using PROs to monitor the US population health, but there are also quality forums that are now taking in PROs as part of their quality metrics. So we will kind of cover some of these categories. So within research, there's a long history. This is probably longer than the clinical use of PROs or public health use of PROs. Here, the issue is that often the PROs are there in collection, but become secondary endpoints. And the difficulty in this situation is that PROs, when they are the third or fourth variable that's analyzed, it can often lead to a false positive error. So it's hard to know in a trial that's not powered to determine if a patient-reported outcome actually changed, if the signal that's being seen in that trial is actually noise, or if it's a well-powered study that can detect that PRO. So what that's led to is the FDA, for example, which is the Federal Drug Administration here in the United States, or the European Medicines Association that monitors and approves medications in Europe, has recommended that PROs should really be a primary endpoint if that is the labeling claim. So for example, if a new pain medication is being developed, the trial should be designed so that it is adequately powered and designed to analyze that particular pain measure. In addition, that PRO should be collected directly from the patient. So not from the clinician who's seeing that patient during a clinic or trial visit, not from the research coordinator, but directly from the patient, which means that we need well-validated tools. And then finally, PROs have progressed, especially in the cancer literature, where adverse events are being collected directly from patients, because this has been shown to provide less bias during collection of AEs, meaning during the interpretation of a patient telling you about their diarrhea from their chemotherapy, there's some loss in signal. And so if you collect it directly from the patient, you're much more likely to get a more accurate signal. And what that's led to is development of a common terminology criteria for adverse events that is now used for and really those headed towards FDA approval of medications. In clinical use, I'll just shift to clinical use. As I mentioned, there's sort of levels where PROs can be used. At the micro level is where clinicians will be most familiar. It's really in that patient to clinician interaction. However, PROs can also be used at higher levels, for example, in the meso level to understand variation in healthcare that's provided within a system, between systems, or even between providers. For example, in the UK, PROs are being collected for many orthopedic surgeries to allow patients to gauge which health system and provider is able to achieve the best functional status or quality of life after, for example, a knee replacement. In the macro level, as I've given you some examples, PROs can be used to monitor population health, as well as guide policy when those markers and metrics are not being met. So I'd like to focus some of our time on clinical use of PROs and how it can inform clinical care through decision-making and monitoring during visits. This is where there's a great deal of literature, so I'd like to kind of dive into that. And really, I want to use these examples to highlight some of the lessons learned from these prior trials and where I think the future of PROs in clinical use is headed. So we'll start kind of at the bottom of the list, largely because this is where the best data is. So how can we use PROs to monitor patients individually between visits? And if you think back to the example that I gave you of a patient with decompensated cirrhosis, I think this is a great example of where liver disease needs to head. But as there's not much data, I'm going to talk to you about some trials in the oncology literature. So this is a trial that was done here in the United States. It enrolled individuals who were initiating chemotherapy for several metastatic cancers. So not early stage, but really advanced metastatic malignancies. These patients were enrolled based on their experience with computer use, so both computer experienced and experienced, and they were followed for primary outcomes, both in change of quality of life as their primary outcome, that was what they were powered for, but also for overall survival. These patients were asked to measure their symptoms using a web-based interface. So they were given a website and then they were asked to go in once a week to report their symptoms in several domains that were related to the chemotherapy, predicted side effects, for example. And this trial was really ingenious in that they had a priori decided what score change would lead to an email and alert to the so really, anytime a symptom worsened by more than 2 points or reached an absolute threshold, an email was sent to the nurse, and then the nurse had a predefined clinical pathway for how to deal with that symptom. And because of that very clear, this is what will cause me to react, and this is what I will do, the patients had a very clear plan for, as they reported their symptoms, what would happen. In addition to the nurse being involved, this tracking and sort of trend of their quality of life and their symptom burden was printed for clinicians and given to them at each of their in-person visits. And as I mentioned, the primary outcome was quality of life, but they actually also looked at survival. So on the left side of this slide is change in quality of life over time in the patients who are in usual care compared to the STAR, the web-based symptom monitoring system. And as you can see, more patients were in the improved category as compared to the usual care. And there were definitely more patients who had worsening symptoms in usual care as compared to the intervention. In addition, they followed patients for how many ER visits they had and were able to show that compared to usual care, monitoring for symptoms between visits with really just weekly nurse-to-nurse interactions, they were able to reduce emergency room visits. And then finally, this is true in both experienced and computer inexperienced patients. And then as the trial completed, they followed patients for survival and were able to show a significant survival benefit over years of follow-up. In fact, patients survived more than 2 months longer in the PRO group compared to usual care. And mind you, they're getting the same chemotherapy. So after the trial was completed, the researchers went back and looked at what what was the reason for this improved survival? And what they hypothesized is that most of these patients were able to tolerate chemotherapy for much longer compared to the usual care comparison group, and thought this might be the reason for overall survival. Now, they were not powered for this particular analysis, so that's still a hypothesis, but still really meaningful data purely by talking to patients more often in a more systematic way. Another example also in the cancer literature is a trial that was done in France. This is patients with advanced lung cancer who had transitioned to a sort of a non-progressive therapy where they were on maintenance chemotherapy. And again, patients were monitored weekly for a symptom burden. If you can see, hopefully on your screen, some of the symptoms are weight loss, appetite, weakness, pain, respiratory symptoms, depression, etc. And this specifically to follow a protocol. So they had clear cutoffs for when the team would be alerted. Here in this case, it was a score greater than a certain amount. And then led to a clear pathway for what would happen in terms of interactions with the healthcare team. And what they looked at is overall survival at 2 years. And then they also looked at change in quality of life through a tool called FACT. They also analyzed cost of care. And what they were able to show in their pilot data and then in the formal trial is often these changes in PROs signaled early scans, which led to early detection of recurrence of cancer, which led to change in chemotherapy. And with all of that together, they were able to show an incredible overall survival in the intervention group, where PROs were followed weekly as compared to the control group. And this trial also looked at, as I mentioned, quality of life, and were able to show improved quality of life just by monitoring the symptom burden in these patients. And they were also able to show a cost benefit of about 400 to 500 euros in patients who were in the intervention arm as compared to the control arm. So not only were they able to improve survival, but also the quality of life in that extended lifespan, and cost savings simply by following a particular set of symptoms in between visits is what I would emphasize. So these trials really are sort of stellar examples. Now, there are many other ways to use PROs, as I mentioned, beyond the sort of the symptom monitoring. So this is an example of monitoring a set of patients with chronic disease, anywhere from heart disease, epilepsy, rheumatoid arthritis, where essentially patients were referred to this questionnaire. And then again, the team sort of monitored the responses based on change. And then if there was a significant change, the patients were either called or brought back to the clinic visit earlier, essentially was the goal of the study. So this is an example of what the team would see. So this is a patient with epilepsy. And as you can see, they monitored many symptoms, including some that are general and some specific to epilepsy. They monitored them over time. And then if there was a significant change, the nurse or the healthcare team member had a clinical pathway to act on. And what they found really is that almost half of their patients in this monitoring group were brought back early because of symptoms they were reporting between visits. And unfortunately, they have not yet published follow-up data to talk about cost of care or what really happened with those patients who were brought back early. But it's really a clear example of not wanting to wait between visits, connect with patients to see how they're progressing, because at least half will tell you that they're not doing as well as you thought they were doing prior to their next appointment. So if I can move on from the examples of how to use PROs between visits, the PROs can also be used to help guide decision-making at the one-on-one level. And a great example of this is in the orthopedic surgery literature. So for example, this is a screenshot of a decision tool that was developed for orthopedic surgery, where essentially a patient can go in and at the top panel tell the tool what is it they're looking to improve. Is it physical function? Is it pain, sleep, Is it their overall symptoms and quality of life? And then based on data that's been collected for individuals who are undergoing that particular orthopedic surgery, they are given some output as to what their physical function, for example, is this particular screenshot, what it will look like if you do not have surgery in this red line as compared to the green line, which is the national average for people in the United States, as compared to what will happen with surgery. It also gives the patient some outcomes data, including how many people need repeat surgery, and what happens to people if they choose not to have surgery, what happens over time. So really a very personalized tool based on PRO data that was already collected, and then targeting it to the patient who's trying to make a informed decision with their clinician. Another example of PROs in clinical use is more related to how to inform clinical care at the time of the visit. And I'll share with you an example in primary care. This is a study done here at Indiana University within our FQHC center. So really some of our more impoverished patients that are in the community. And essentially they used that NIH developed PROMISE system to measure symptoms in primary care. They randomized patients coming to primary care clinics to either complete the domains, these 5 domains that were going to be measured at the time of the visit versus not. And then the clinicians were provided a report for those who completed the quality of life questionnaire. And then the quality of life was measured over time. And that was really what the trial was looking at, is did the clinicians incorporate the scores that were measured at the time of the visit into their treatment plan? And how did that impact quality of life 3 months later? What they found, or let me just stop and show you what the clinicians saw. So for example, these are the 5 domains: fatigue, pain, sleep, anxiety, and depression. And what the clinicians saw were these bars where some of them, if they were indicating a poor quality of life in that particular domain, the bar was red. Given sort of a cutoff score to think about, with 55 being what the researchers shows. And they were also given a way to interpret it. So for example, the 68 was to interpret that there was a high pain score, which is not good in this patient. So in this trial, what they were able to show is that because of this type of formal presentation of patient-reported outcomes, clinicians documented their symptoms more in the clinical chart. This was most profound for pain, although they also saw it in all of the other domains. And then they also were able to show that patients were, reporting these very easily without any trouble during the clinic visit. Unfortunately, what they saw is, as patients report these symptoms, if you do not do anything about it, if you are not able to successfully treat it as a clinician. So for example, patients who had a change in the score versus not, those patients who did not improve their pain scores had lower satisfaction in the care that we provided. Similarly, if they're fatigued, if they desired treatment and did not receive it and their symptom score did not get better, they were less satisfied with care. So it's really a lesson of, yes, we can measure symptoms. Yes, we can document it, but if we don't do anything about it, we'll actually harm patients by reducing their satisfaction with the care that we're providing. So based on these examples, I'd like to turn to what are the barriers to implementing PROs in clinical care. And it really seems like a quagmire of how to get this done. And what I'd like to focus on, although there are many barriers, as you can see from this table, from a great review on implementing PROs in care, this is actually focused on behavioral health. But if I distill it down, I have a list for you to focus on the left. Really, many of the barriers go around measurement. We don't yet, for example, on liver disease, have validated patient-reported outcome measures that we all want to commit to as a community. We don't yet always know the utility of those PROs. There are not clear data that link a PRO to the outcome that either we as clinicians or the patient are valuing. There's also concern about the burden that it places both on patients and their clinicians and the healthcare system to measure these PROs. And that burden comes from not having management pathways. So as I described in the oncology literature, having a clear set of instructions for the folks who are receiving the scores, having information systems infrastructure to support collecting and reporting of results, and really incentives to invest in all of this to bring us from healthcare 1.0 to really our goal. So to focus on some of these barriers, what I'd like to do is talk about barriers at certain levels and maybe provide some literature as to why some barriers that are perceived are not really there. So barriers that are true are at the patient level are access. So patients who have poor health literacy or do not have digital access will definitely be a group that needs focus on as we go into PROs and measuring them. There's clear data that in patients who have lower health knowledge and health literacy, they are more difficult to engage in collecting PROs, especially between visits, as I had highlighted in some of the prior studies. There are also public health concerns about access to broadband, for example, or internet and Wi-Fi, and if we can even get patients to complete PROs between visits. A burden or a barrier that's perceived by clinicians and health systems that probably isn't true is that collecting PROs is a burden on patients. In fact, there are studies that show that despite completing questionnaires for 10 to 15 minutes, as long as patients feel heard and their PROs are responded to, patients do not feel burdened by a battery of surveys. And there are technologies and sort of advancements in how PROs are collected to reduce this burden. So for example, instead of a static form where there's a set of 15 or 30 questions that we use, there are now computerized adaptive testing where patients, depending on how they answer the first question, may only be presented with one or two, whereas a patient who's answering in a more severe range may be offered more questions to try to really drill down into that symptom or that domain of quality of life. So there are definitely advancements and really probably not a burden on patients as we might fear. However, if we don't do anything with this data, as I've mentioned a few times now, that can become a burden. So for example, there was a study of over 160 cancer trials that found that PRO data was collected in over 50,000 participants, but then was never published, never really analyzed or acted on. And so I think patients, if that is what they're seeing, is that you're asking me all these questions, but then you don't do anything about it, that's really where the burden will set in. So ways to reduce the burden are to think about PROs from the beginning. Why are we measuring it? What's the rationale? Design a trial that includes the PRO development and incorporation into the trial and treatment design. And then really, how do you deliver it so that it's easy for patients and meaningful to them? I think these sort of keeping those themes in mind will help with reducing the burden and barriers that patients face in partnering with us. I'll spend some time really focusing on us as providers. What are we doing to PRO incorporation in clinical care? As we all know, there is a lot of data that we collect. And I think this is a great depiction where really we're staring at a clock. We have, in the US, for example, we have 15 to 20 minutes. That's sort of my time slot to see a patient with cirrhosis who's coming back for routine care. I'm looking at so many different pieces of data. And then to add to it, this kind of patient-reported outcome becomes challenging. And I think I'd like to focus on a few barriers that I personally felt and that there's research around that might help us jump those hurdles. One thing I'll say is that really everyone loves a number, and I really go by this, right? Instead of patients during their history of present illness or their review of systems telling us a story, it really is much more easy for us to digest as clinicians, especially when we're strapped for time and mental capacity to just look at a number. And so I'll give you examples of that. This is an example. My healthcare system uses an electronic medical record system called Cerner. This is a screenshot from that, really of a test patient where a patient was given a PRO tool down here, and we're asked all of these questions, but this is how I see it. And it's very hard for me to interpret these results in a time-constrained pattern. There's a lot of cognitive burden to thinking about all of these questions. How did the patient answer? I don't really have a comparison to what did other people in his or her situation answer this. And so it's hard for me to take this as compared to what I already know. So their labs, their vital signs, which we've been trained through our medical training to quickly interpret and act on. So ways to reduce this burden, it really hinges on how we present results. So this is an example of a effort within gastroenterology to capture patient-reported outcomes that are specific to irritable bowel syndrome. And here what the team did is provide a clear depiction of the patient's symptoms, compared it to the US norm through these color-coded columns, and prioritize the symptoms based on severity. So in this particular patient, while they're having some symptoms of heartburn and reflux and some pain, their real sort of major complaints are around constipation and gas. So this is a depiction where you can imagine as you're seeing the patient, you might even turn your screen and say, I see that you're really struggling with constipation. And while I am interested in talking to you about your abdominal pain, let's focus on constipation today. And really, this can be empowering both to me as a clinician and to the patient to engage in that kind of back and forth without the cognitive burden of reading each particular question, seeing how they answered, and thinking about how someone else in their situation would have answered. Other ways to present this data are simple things that we all have been trained in through our medical training, which are line graphs. This is great, especially for longitudinal data where you can see trends over time. And really important here is having markers for the severity of that symptom, having lines that tell us that below this is a problem or above this is a good thing. So really changing how we interpret, how easily we can interpret a PRO. Another even more simplistic option is the use of this red light, green light, yellow light system. This is particularly useful if you are looking at a lot of domains. So for example, our health system has started to collect health-related social needs. So does a patient have have food insecurity? Are they in an unsafe environment? Do they have mold in their house? Do they have caregiver burden? Because I'm looking at many different domains, it's great to see a red light for food insecurity, a green light for they feel safe in their current environment. And it allows me to focus cognitively on the red light and not worry about the other domains more quickly in my short visit. So I think, like I said, everyone loves a number, but how we present that number and what we, how we interpret it in a clinical setting, I think is really important. And there's lots of literature around that. One way to improve interpretation is something that I'm working on with our group here at Indiana University. So it's really important as we develop these visual tools to have cut points that are clinically meaningful, but also have changes. What is a meaningful change in a PRO? So for example, this is patients with chronic liver disease. The domains that I measured were physical function, fatigue, depression, anxiety. I'll let you read the sort of whole list. And we completed an analysis based on both many different ways to develop a meaningful, important difference in each of these domains. So I can tell you, if you use the PROMIS physical function tool in a patient with cirrhosis, a change of 3 to 5 is a meaningful change in physical function. And then that can be incorporated into those visual tools that I've explained to you. So there's quite a bit of research in other chronic diseases. This is really the first of its kind in chronic liver disease, and I'm excited to hopefully have it published soon. There are also barriers on how to communicate these PROs, again, because we've not been truly trained at how to interpret these results and then communicate them back to an individual. while we're seeing them in the office. There is actually training on improving our efficacy in communicating. There's a whole field called PRO communication or PRO communication, where physicians are able to train in, depending on what your goal is, some tools for how to address those. So for example, managing uncertainty is a really difficult situation where you can use PROs to guide a decision point where, do I want a TIPS or should I send you to transplant, for example? And that would be a great example of learning how to communicate a PRO that you've measured before you make that decision. So there's definitely training in place that is not yet adopted into regular care, but is available. I'm going to shift away from the provider to talk about health systems and how they can be either barriers or partners to PRO measurement. So this is an example, again, from our own, from where I practice at IU Health. And this is that social determinants of health screening. So essentially patients are asked about their personal characteristics, their income, safety of their housing, other resources that they have. We know that these can impact the outcomes of the clinical care we provide. Now, it's great that we're measuring this, but interpreting and how it's implemented into the EMR is really key here. So for example, this is what a case manager in our health system sees once a patient completes the PRO. It's incredibly complex, it's color-coded, it's hard to interpret, there's no clear guidelines for what to do next. So it's great that we're collecting it, but our EHR really fell short here in how to then present it to the person who's going to respond to it. So what our health system is doing is actually partnering with an outside platform called Zelf to orchestrate collection of all of these PROs, allow clinicians to, for example, order a PRO that is sent to the patient via email or SMS or the existing health portal that we have. It then brings the data back into our EMR, not only allows us to see the results, but then also to analyze it both for the patient, perhaps for my particular panel of patients, and even the health system itself. So it's really the health system, as it starts investing, is able to help me through all of those steps as a clinician. And so, for example, this is what our EMR will hopefully look like once we are able to get onto this platform, where a patient with diabetes, in this example, I'm able to give them a video to talk about healthy eating or what kind of sweetener they should be using. I might be able to tell them, you had shoulder pain and here's what wrote, here's some things that you can do. So, and it lets me see as a clinician or as a nurse that the video was watched, that the patient completed the questionnaire, here are the scores. So I'm really excited to be part of a health system that is taking this on. Really, so the barriers that I've mentioned, I think can be addressed, and the field that I think is most poised to do it is what we call implementation science. Implementation science is an arm of a clinical research that really focuses on developing the tools, the processes and strategies that are needed to take what we know from research and get it to the patient's bedside, into the real world. And I think patient-reported outcomes, we're sort of right at that cusp where we have a lot of research. We know that it's important, but we are struggling to bring it into the real world. And this is where I believe the next generation of anyone who's managing chronic disease, including hepatologists, can focus their efforts. So what about liver disease? Why is a hepatologist talking about this? What I'll tell you is that currently there's actually no ongoing clinical trials where PROs are guiding the clinical decision-making or the clinical care. So all of those examples that I've described are outside of the liver literature. There is one particular study that was done by Dr. Verma that looked at, can patient-reported outcome measurement happen in liver disease care? So these were patients who were coming to the clinic for cirrhosis-related care. Almost all of them thought, the patients themselves thought, that measuring PRO was useful to them and to their provider. 88% of those interactions, the providers noted that the scores helped them. So both the patient and the provider felt that there was a benefit. On the left is what I'm showing you is what the clinician was shown. So again, sort of a way to easily interpret some of the domains that the patient completed and what it means compared to the population and really in terms of severity. And then they looked at some of the markers of burden. Did the clinic visit go longer? And actually for most clinic visits, they were either unchanged or a little bit shorter. So only a third of visits were longer, but I would argue they may be longer because the clinician had more information to interact with and it was a more meaningful visit. In fact, they were able to show that a quarter of those visits, the score interpretation led to a change in the treatment that wouldn't have been done otherwise. And in fact, afterwards, half of those patients actually had improved quality of life because these domains were measured and then the interaction was more meaningful. So this is really the first study, and I have not seen follow-up since then. They did not really get into what about the. There are older studies where we have shown that PROs are clearly linked to clinical outcomes. So both, all quality of life, functional status, measuring self-reported nutritional status, all of these can then be linked to hospitalization, disease severity. In fact, it is also linked to mortality. So this was a systematic review done by Dr. Verma and Dr. Yunisi, where they looked at all trials within liver disease in the liver disease population and found 4 trials where they made this particular connection. In our own group here at Indiana University, we've shown that collecting PROs can actually improve prediction of readmission for individuals who are hospitalized for cirrhosis. So here we built a model where we initially just started with what's in the EMR. Then we added some of the more liver disease specific clinical variables. Then we added socioeconomic variables. And then the last model, we added functional status that is reported by the patient as well as quality of life. And this study is already published, but just to highlight, essentially functional status and quality of life as reported by the patient improve the model performance from just what's available in the EMR and from what we as clinicians collect. So I think a meaningful ability to improve what we can predict for patients after they leave the hospital. We also know that PROs are responsive to treatment. So there are trials within hepatitis C as well as liver cancer and those with HIV and hepatitis C, where measuring quality of life and symptom burden can help us with determining the effectiveness of a treatment, determining comparative effectiveness. So for example, this trial in liver cancer compared transarterial radioembolization or Y90 treatment with transarterial chemoembolization. And while both had similar impact on survival, the Y90 treatment had much better improvement in PROs as compared to TACE. And I think that's a really meaningful conversation to have with patients as we decide on treatment. In my own group, we've also looked at how disease progression impacts quality of life. And, in the interest of time, I might start to just speed up a little bit. But for example, treating alcohol use disorder in patients with alcoholic hepatitis by achieving abstinence, their mental, which is the top bars, and their physical quality of life improves. We also know that as their MELD improves, their quality of life improves. More importantly, as we treat their ascites and their encephalopathy, we're able to improve their quality of life. And so measuring what patients are telling us is tightly linked to how their liver disease progressing. We've also, in my own group, measured how healthcare quality of life changes after transplant. So this is a large cohort of individuals that were enrolled both at University of Arizona as well as Indiana University. And we measured quality of life in the many domains that I've shared with you before at several stages. This includes the blue bar, which is inpatients that are admitted with decompensated cirrhosis. The orange bars are outpatients who have cirrhosis. The gray bars are outpatients who have chronic liver disease, but have not yet progressed to cirrhosis. And then the yellow bars are patients with after transplant. The line at 50 is where the US population scores on average. And as you can see, depending on the domain, as patients go towards transplant, their quality of life becomes closer and closer to the United States mean. In fact, many of them, you don't even see the yellow bar because, for example, their anxiety levels come back to the population mean. Their depression scores are near the population mean. The fatigue is. But what's interesting is physical function remains perturbed despite transplantation. And so this gives us a realistic view of what transplant can achieve for an individual and what transplant cannot achieve for individuals as we treat them and guide them through the transplant pathway. We've also looked at PROs after transplantation. So this is a group of 200 individuals that we studied here at IU, and we measured beyond quality of life. We looked at health literacy, chronic disease burden after transplant, mental quality of life, so psychosocial things like traumatic events that they've been through. Do they have PTSD symptoms because of the severity of their liver disease and their near-death experience? Do they have financial distress because of all of the healthcare costs that they have incurred? On average, the patients that we surveyed were quite far from transplant, almost 7 years on average, and most of them received a liver transplant alone. And what we found is that many patients report traumatic events during this time. So not just the life-threatening illness, but also they have a high burden of other trauma that they've endured as they've gone through their transplant journey. And we also noticed a great financial distress in our patients. So over a quarter of our patients were spending more than 10% of their income for out-of-pocket medical costs. Many of them had to pull out of their savings. A third of them actually forego medical care or delay it or skip tests or space out their medications to be able to afford care. And this is after transplant. So as you can imagine, this has great impact on the longevity of their graft, as well as the outcomes that we care about after transplant. In fact, we found that because of the experiences and the healthcare costs that they incurred as they survived their liver disease. So I think these are really meaningful to individuals and for us as clinicians to say, what are we really able to achieve after transplant? What is the cost of pursuing transplant? There's also clear data that cognitive function is not normal after transplant. So this is a study by Dr. Serper, and really she took multiple studies and tried to put them together. And most studies showed that these cognitive domains in attention, executive function, memory, language do not improve despite transplantation. So going back to really what does this mean for liver disease? I believe that here we need further characterization of patient-reported outcomes in liver disease. We need to expand beyond quality of life. I've given you some examples. Another example that I'll share with you really comes from this scoping review that was done by Dr. Tapper and the whole practice metrics committee at the AASLD here in the US. And what they looked at all is what are the domains of PROs that are currently in the literature? And many of them focus on the physical and social, but there are very few studies that look at, for example, health literacy. So this is a study that my group completed here at Indiana University, as well as University of Arizona, where we looked at health literacy. And it turns out there's actually no validated tool to measure health literacy when it relates to liver disease. And so if there's no tool, we cannot measure it. So we focused on developing a tool that we called My Cirrhosis Coach, and we were able to show that many patients have barriers. So only 20% had the ideal access to their medications. Very few patients had ideal understanding. Over a third of patients reported medical obstacles to their care. And very few patients, despite having encephalopathy, having ascites, or having varices, very few of them actually understood what lactulose does, what a diuretic does, what are the side effects to look for when taking a beta blocker. They really did not know how to limit salt, for example. So by being able to measure this in a more systematic way, we now are poised to do a trial where we will try to improve this knowledge and then link it hopefully to improved outcomes. I think the other things that our hepatology community needs to embrace in terms of PROs is how to implement them into our care. So I think we have great examples from orthopedic literature, from oncology literature, even within rheumatology. There are many studies that I didn't have time to cite where they are working to take these measurements and bring them to their bedside. So that's really the focus of my future research is within that implementation science arm. And what we need is to be able to partner with our healthcare system and really be champions as hepatologists and gastroenterologists to say, I won't accept a system that doesn't support these needs, so that we incentivize the system that we're within to really center our care towards the patient and what they value. So I'll stop with some takeaway points. I think patient-reported outcome measurement is really an integral part of future clinical care. We all are versed in doing it, and there are ways and there are barriers to current uptake, but I think implementation science research has shown that we can overcome these barriers, especially if we couple it with providers who are champions for their healthcare system to really improve engagement. And finally, I think patient-reported outcomes are clearly important in liver disease, but how we use them in liver disease as a chronic disease is quite uncharted, and where we should all head. So I'd like to just stop and thank my mentors, including Dr. Chalasani. My other mentors who really inform my work in the PRO world are Dr. Bustani, who's a geriatrician, and Dr. Monahan, who's an expert biostatistician in how to analyze PRO data, as well as my whole team and colleagues. Thank you. I'll stop here.